Post-gastrectomy complications. Dumping syndrome. Can occur after gastrectomy or after vagotomy and pyloroplasty. Occurs from rapid entering of carbohydrates into the small bowel. 90% of cases resolve with medical therapy. 2 phases. Hyperosmotic load causes fluid shift into bowel, hypotension, diarrhea, dizziness. Hypoglycemia from reactive increase in insulin and decrease in glucose, second phase rarely occurs. Can almost always be treated medically, and dietary changes. Treatment: small, low-fat, low-carbohydrate, high-protein meals, no liquids with meals, no lying down after meals, octreotide. Surgical options, rarely needed. Conversion of Billroth 1 or Billroth 2 to Roux-en-Y gastrojejunostomy. Operations to increase gastric reservoir, jejunal pouch, or increase emptying time, reversed jejunal loop. Alkaline reflux, gastritis. Postprandial epigastric pain associated with nausea and vomiting, pain not relieved with vomiting. Diagnosis. Evidence of bile reflux into stomach, histologic evidence of gastritis. Treatment: PPI, cholestyramine, metoclopramide. Surgical option: conversion of Billroth 1 or Billroth 2 to Roux-en-Y gastrojejunostomy with afferent. Limb 60 cm distal to gastrojejunostomy. Chronic gastric atony. Delayed gastric emptying. Symptoms: nausea, vomiting, pain, early satiety. Diagnosis: gastric emptying study. Treatment: metoclopramide, prokinetics. Surgical option: near total gastrectomy with Roux-en-Y anastomosis. Small gastric remnant, early satiety. Actually want this for gastric bypass patients. Diagnosis: upper endoscopy. Gastrographin study. Treatment: small meals. Surgical option: jejunal pouch construction. Blind loop syndrome. With Billroth 2 or Roux-en-Y, caused by poor motility. Symptoms: pain, steatorrhea, bacterial deconjugation of bile, B12 deficiency, bacteria use it up. Malabsorption. Caused by bacterial overgrowth from stasis in afferent limb. Diagnosis: upper endoscopy of afferent limb with aspirate and culture for organisms. Treatment: tetracycline and flagyl, metoclopramide to improve motility. Surgical option: reanastomosis with shorter, 40 cm, afferent limb. Afferent loop obstruction. With Billroth 2 or Roux-en-Y, caused by mechanical obstruction of afferent limb. Symptoms: abdominal pain, steatorrhea, non-bilious vomiting, pain relieved with bilious emesis. Risk factors: long afferent limb with Billroth 2 or Roux-en-Y. Diagnosis: CT scan. Treatment: balloon dilation may be possible. Surgical option: reanastomosis with shorter, 40 cm, afferent limb to relieve obstruction. Efferent loop obstruction. Symptoms of obstruction: nausea, vomiting, abdominal pain. Diagnosis: upper endoscopy. Treatment: balloon dilation. Surgical option: find site of obstruction and relieve it. Post-vagotomy diarrhea. Secondary to non-conjugated bile salts in the colon, osmotic diarrhea.